Hello, my name is Sam Klempner. I'm a GI medical oncologist at Mass General in Boston. I'd like to thank Dr. Davis and the rest of the committee and Debbie's Dream for inviting me to this symposium. I'm going to try to give a talk about stuff that nobody tells you, which is really about standard of care, because I think it's really important to have a foundation. And this is stuff that unfortunately is not covered well by many of us, including myself at times, just because we have tight on time and visits. Here are my disclosures. So we're going to talk about staging, which is really asking the question of what is the burden of my disease. Then we're going to talk about treatment of localized disease, specifically on FLOT, which is a standard. Then we're going to talk about the broad approaches to advanced disease and how important it is to know the tools. Then we'll talk a little bit about the basics. So why do we stage people at all? It's probably the most common question that patients, when they're newly diagnosed, or caregivers and family want to know. And the reason is that people know that staging tells us a little bit about your prognosis. How likely are you to survive X period of times? These things that are very important in terms of informing how people approach their cancer. So staging is built upon the TNM system, which is tumor is T, N is lymph nodes, M is metastases, and you add all these up to get an overall stage. So here on the graphic on the left, you can see that the T stage increases as the tumor invades more deeply through the layers of the stomach. This is also applicable to the GE junction and esophagus, but this talk is focused on the stomach. And then you see down here, you see a lymph node that's not involved, so that's an N0. And then you see N1, 2, or 3, depending on the number of lymph nodes that are involved. And then M if there is spread to other organs. So stages 1 through 3 cancer is localized to the organ where it started, so in this case the stomach and the regional lymph nodes, and the goal is cure. Stage 4 disease has spread to other locations and unfortunately is rarely curable. In select situations, we do approach the problem with a goal of cure, but that is the vast minority of patients, sadly. So what do you need to know your stage? So in stomach cancer, what you can see on the left is the workup that's suggested by the National Comprehensive Cancer Network, and this is an excellent place to start. They have very good guidelines for patients as well that outlines all of this. You need some form of imaging, and the imaging is primarily used to look at areas outside the stomach, liver, lymph nodes, lungs, etc. And that can be a CT scan of the chest, abdomen, or pelvis with contrast, or it can be a PET CT scan, which is becoming more and more common and maybe a little bit more sensitive for detecting small areas of involvement like occult lymph nodes. Ultimately, you need tissue to confirm the diagnosis. I think everybody knows that. And that's obtained usually via an upper endoscopy where a camera goes down the throat and then there's a small grasper that takes a bite of a mass or area of concern. To get that T stage that I showed you where you're looking at the depth of invasion, you really need an endoscopic ultrasound, which is another procedure or done at the same time to measure the depth of invasion and sometimes look at lymph nodes that are right next to it. Often overlooked is the importance of a staging laparoscopy. So we know that people who have tumors that have invaded, say like T2 or T3, in some series there's almost a 20% chance of having disease hiding in the lining of the abdomen called the peritoneum. So in patients like that, it's quite important to understand if there is occult disease in the abdomen, and unfortunately CT scans and PET CTs do not evaluate the lining of the abdomen, the peritoneum, very well. So a staging laparoscopy is usually an outpatient procedure where the surgeon puts some air into the abdomen, puts a camera and looks around and takes any biopsies and washings to make sure that there's no disease hiding in the lining of the abdomen. This is the sad reality, and I don't mean for this lecture to be depressing, and I hope it offers actually hope. But it's also important to have all the information laid out when you're making your decisions in a framework of shared decision making with your care team. So as you can see, these are figures from the United States, and what you can see is that almost 40% of people by the time they're diagnosed already have stage 4 disease, that it's spread to other organ. And then there's about almost 55% who have regional or localized disease, still confined to the stomach or surrounding lymph nodes. And again, you can see why staging is important, because you can see the survival is very different. If you have a localized disease with no lymph node involvement, the 5-year survival is around 70%, and some series even better. If you have regional disease spread to the lymph nodes, the 5-year survival drops off a lot to around 33%, which is quite bad. And then if you have stage 4 disease, the survival at 5 years is a very, very small minority of patients. Only 5.5% of patients are alive. Certainly this is nowhere near good enough. And people like myself and Dr. Davis and many others, our whole job is to make these numbers better. So if you have disease that's localized or regional, the therapy is usually something before surgery. That's usually neoadjuvant therapy. And neoadjuvant therapy is essentially a treatment prior to a surgery with the goal of cure. What I'm showing here is the figure about why we do neoadjuvant therapy. So the red circles represent the tumor and the lymph node on your stage. So in this case, the patient is a T3N1 M0 because there's no metastases seen on imaging. But what we know is that some patients have disease that we can't see with any of our tests. And those are called micrometastases, microscopic disease that we can't see. So the goal of neoadjuvant therapy is to give something, usually chemotherapy, to kill those micrometastatic disease prior to an operation, and therefore increase the chance of cure and decrease the risk of recurrence. I should also know that a very hot area that a lot of people ask about is circulating tumor DNA and blood tests. And we are actually making major inroads into detecting micrometastatic disease with blood tests. So over the coming years, I think we're going to get much better at detecting disease that we can't see on scans, and that will ultimately help us manage our patients better. This is a cartoon. That's Dr. Davis, who's an excellent surgeon. In case you don't know him, he's also the host of this symposium and webinar. This is broadly how we think about locally advanced stomach cancer. So you get diagnosed and you get staged, that's over on the left side. Then you get neoadjuvant chemotherapy, so that's your treatment before surgery. And then you get surgery, and then you get adjuvant chemotherapy. This, if you add all this strategy up, neoadjuvant plus adjuvant, that's called perioperative. In Asia and sometimes in the United States, patients are diagnosed and staged, and then they go to surgery right away. And then in that case, the most common management is adjuvant chemotherapy, which is treatment after a curative intent surgery. So FLOT is a perioperative approach, which I'll walk you through now. So again, on the top here is just a reminder of this is what it looks like. You get 4 cycles of FLOT, then you go to an operation, then there's some time for recovery, and then you get 4 cycles of FLOT after surgery. That's what they did in the very large trial, and that is probably the gold standard for stomach cancer in the United States. As you can see on the lower panels, these numbers are still not good enough. So even if you go through FLOT, the median time to recurrence is about 30 months, and the median overall survival is about 50 months. So that's only a little bit over 4 years. FLOT is 5-FU plus oxaliplatin plus docetaxel given every 2 weeks. The chance of being alive in 5 years is about 45%. And it's quite sad, many patients still recur despite this intensive therapy. The quality of your surgery, having your surgery by someone like Dr. Davis, is actually quite important. Higher volume surgeons and bigger centers have better outcomes. And so we still need to do much better. There's one caveat to this, which is very important. And this is people who have microsatellite unstable or mismatch repair deficient tumors. So in people with non-metastatic disease, stages 1 through 3, the frequency of this is somewhere between 8 and 20%. And the reason that's really important is this curve on the left. So what you're seeing here is MSI high patients and MSS patients. And people who are MSI high, they really don't get that much benefit from chemotherapy. So at our institution and at many others, we check these patients, stages 1 through 3, at diagnosis for MSI status. And if they're MSI high, we're either going right to surgery or we're considering immunotherapy leading up to a surgery. And there's a lot of emerging data to support this idea. But we're avoiding chemotherapy essentially completely because these data here suggest that those patients are not benefiting from chemotherapy. So remember, if you're newly diagnosed, stages 1 through 3, you need to have MSI testing, and you need to talk about how that's going to impact your management with your care team. So we're going to move on from a localized disease to advanced disease, and I'll leave you with some questions that I think are important to ask your team if you're in this scenario. So always want to know what your stage is. That's like a word that can mean a lot and carry between teams. If you ask someone else for advice and say, I'm a stage 2 patient, it's very important to know your stage. It's very important to ask your care team if they're considered a staging laparoscopy, because this is an important way to rule out disease that's hiding in the lining of the abdomen. You need to ask, in my opinion, did we test mismatch repair or microsatellite instability? Because you want to know your status, because it might impact how your team treats you. And then finally, we're learning a lot, and it's certainly clear that patients who have multidisciplinary conference discussions do better. The staging is more accurate, so you're less likely to miss something if there's multiple sort of eyes on your case. If their doctor's talking about it with 3 or 10 other people in a conference, it might pick up something that he or she missed, and that's just benefit to you. And so we have a big multidisciplinary conference where we discuss all the new patients, as do the majority of large cancer centers, and it is for the benefit of patients. All right, now we're going to transition to the second half of the talk, which is really about stage 4 stomach cancer. So unfortunately, we wish we never had to have this discussion, but this is the reality for many patients. As we saw, about 40% of patients, when they present to the office or present with trouble swallowing or feeling full, they already have stage 4 disease. That's just a fact. The schema, the picture on the left just shows as a reminder, primary tumor is in the stomach. When we say primary tumor, that's what we're referring to. And the sites of spread are where the metastases are. In this case, you see liver and lungs. So treatment is all about the right tool for the right job. That's true of many jobs. And first, you got to know what your tools are. And so when you're going to your oncologist's office, the tools that your oncologist and your care team is working with are chemotherapy, immunotherapy, biologic or targeted therapies, radiation, surgery, and in my opinion, critically, clinical trials. So this is a reminder. Many people want to get away from chemotherapy. I totally get it. We would love to have therapies that are good enough that we can get away without chemotherapy, but for the vast majority of people, we're not there yet. So this is a reminder that almost all stage 4 stomach cancers need chemotherapy. Frontline or first line is the initial treatment combination you receive in advanced disease. So you can see this very maybe not good cartoon that I made here, where you have a starting place. That's when you're diagnosed with stage 4 disease. First line, that's the first thing you get. And then you get some scan, hopefully not for a very long time, but ultimately it may say, okay, this first line therapy is not working anymore. Maybe you get a biopsy to retest some stuff we're going to talk about. And then you go on to second line, and I've just included some common second line and third line, and I think you kind of get it from here. First line, I put the most common chemotherapies under the line of therapy, and so I don't know if it comes through, but K-pox, that fox is supposed to have a cape and a mask on. Paclitaxel, those are taxes. That's supposed to be someone irritated under full fury, and that's obviously someone surfing under TAS 102. Is the brand name is Lawn Surf. I don't know, it's just the way that I remember it. Actually saw one of the nurses from a chemo infusion center go as full fox for Halloween costume, which was awesome. Just like the G.I. Joe cartoons, if you were a child in the 80s and 90s like I was, you remember this at the end of every episode. Knowing is half the battle, and that's really true for oncology too. Biomarkers are things that tell us something about your tumor. There's two flavors. There's predictive biomarkers. They can be positive or negative, and they basically tell you, are you more or less likely to respond to a given therapy? And we're going to talk more about that in a minute. Prognostic biomarkers tell us about the biology of the cancer. Is this an aggressive disease that might be associated with a shorter survival, or is this perhaps a less aggressive disease that may do better? For example, microsatellite high patients do better than microsatellite stable patients in general. This is really perhaps the most important slide of the whole talk, and it's just a reminder that biomarker testing is critical for everybody with stage 4 disease. This is the bare minimum. You need to have this done if you have stage 4 and arguably even some locally advanced cancers, but HER2, which many of you have probably heard, is a gene that is amplified, or a protein that is overexpressed in about 12 to 20% of patients. It's predictive of benefit from Trastuzumab. So if you have the amplification, you are more likely to respond to the drug. PD-L1, we'll talk a little bit about it. All stage 4 patients, in my opinion, need to have this tested. It's positive to some degree in most patients, but the degree of positive actually matters, and we're going to talk about that. This is associated with benefit from checkpoint inhibitors like pembrolizumab and nivolumab, and I put the brand names there for reference. Microsatellite instability or mismatch repair testing. Again, this is positive in a small group of patients, a small slice of the pie, but it's very important because it's very tightly associated with benefit from immunotherapy. And some of these patients arguably may not even need chemotherapy. So we're going to talk about the current targets now. I wish this was how we discovered targeted therapies. It seems way more fun sometimes, but what can you do? So HER2 testing and Trastuzumab benefit. So normal cell is seen up on the top left. So HER2 is a normal protein, it's a normal gene, and it responds to signals from outside the cell about growth and things like that. If your tumor cell has too much of the protein on it, too many copies of the gene, then the signal is like always turned on. And you don't want a switch that's always on, because it's like having a signal that says grow, grow, grow all the time. And that's bad for, it's what cancer wants to do, is grow, but it's bad for cells because they're having uncontrolled growth. Too much HER2 can be looked at by looking at the protein or the number of genes, or both. And this can be done by immunohistochemistry, something called FISH testing, or something called next generation sequencing. The reason it's important is that if you have overexpression of HER2, your survival is better when you get this drug. So shown in the top right is something called the TOGA trial, and this first established that adding HER2 to HER2 positive patients improves survival, and you can see the median survival over there in months. And so this is important. Obviously, we need to do much better, and we're going to talk about a new kid on the block with regard to HER2 in a little bit. We're going to talk about immune therapy, but it's important to have a very brief immune refresher. So these are the lymphocytes. The most important group in the lymphocyte gang for you to probably have some familiarity with is the T cells. These are the cells that are most commonly associated with clearing out and killing tumor cells. specifically the cytotoxic CD8 positive T cells. That's what I'm highlighted over there in the left. So just taking a step back, why do you even have an immune system? Just like the police slogan, it's to protect and serve, and that's against external stuff. So bacteria, fungus, viruses like COVID, etc. It also plays a very important function of recognizing and serving, which is going around all day and checking out your cells in your body and making sure that they look normal. And those are self. If for some reason they look altered, then they shouldn't be there. That's a warning sign. And cancers look different than normal cells, and so your immune system is supposed to recognize them as non-self in some way, even though they look a lot like self, and then clear them out. When your immune system is going haywire and recognizing normal cells as abnormal, you can get autoimmune disease. A brief word on PD-L1. So again, this is scored by a system called CPS, or Combined Positive Score. You should ask your oncologist or one of your team members, what is my CPS score? What is my PD-L1 score? And basically what it's looking at is shown over here on the left. So when you get an infection, you need a system that ramps up your immune system to turn it up and fight the infection. You also need a system to turn it back down, otherwise you'd live always in a very revved up immune state, and that would be harmful. So PD-L1 expression is a normal way to turn down your immune system, and it inhibits the T cells from reacting against tumor cells. That's a bad thing when it's cancer, because it's a way for cancer cells to sort of hijack a normal immune mechanism and use it to their advantage to avoid getting killed by the immune system. It's also a marker that tells us how likely you are to benefit from adding immune checkpoint inhibitors like nivolumab or pembrolizumab, because what they do is interfere with that interaction. So on the left cartoon, you see PD-L1 engaged with PD-1, and that is shutting down a T cell, and the cancer cell is alive, the yellow cell. When you interfere with that, it's like some people have compared it to cutting the brakes. When you cut the brakes, now your T cell is unleashed, and I put that picture of the little CD8 T cell with the sword. Now he can go, or she can go, and kill the tumor cell. And so a lot of stomach cancer patients are positive for PD-L1, but the degree of positive, the actual score, matters. And this can change over time. Sometimes we need to consider repeat biopsies over time. So just to dig a little bit deeper, immunotherapy is really hot right now, and this is why some patients should get immunotherapy and other patients arguably should not. So if you look at this data, this is from a big trial called Checkmate 649, and you see the space between the two curves. That reflects the magnitude of difference between one group getting chemotherapy alone, which is the red line, and one group getting nivolumab plus chemotherapy, that's the blue line. And you can see that their survival was about 3 months better if they got immunotherapy. But that's only for people that had a PD-L1 score, a CPS score of 5 or higher. If you look at the less than 5 or other groups, you see that there's actually very little difference between the two groups of patients, and the space between the curves is much smaller. So the magnitude of benefit is much less, and you can make an argument that those patients are not really benefiting from immunotherapy in the PD-L1 low patients. So immunotherapy is not a one-size-fits-all solution for stomach cancer, and the score matters. And so you should ask and know your score. This brings us back to the mismatch repair and MSI-H question I mentioned earlier. So MSI low, or microsatellite stable stomach cancers, which is about 95% of stage 4 patients, the DNA looks like this. So you have 2 strands of DNA, and they're these bases that pair together, and there's periodic mutations that just accumulate in cancer over time. But there's actually not a ton of them. In patients that have mismatch repair deficient tumors, their mutation is basically makes it so the DNA doesn't have a normal autocorrect, like on your text message when you're texting and it autocorrects because you've misspelled a word. Your DNA normally has a system, if there's an error in the pairing, to eliminate that and correct it. Cancers that can't correct those errors accumulate thousands of mutations. And that's what I'm showing in the bottom part on the left. What that means is that if you have a lot of mutant proteins, because the DNA ultimately encodes the protein after RNA, then what you have is a bunch of proteins on the surface of your tumor cell that are no longer normal because they have mutations. Remember, your whole immune system's job, one of it is to look and identify self and non-self. And so if your cancer has a ton of mutations, there's a better chance that your immune system is going to recognize it, and there's also a much better chance that you'll have a response to immunotherapy because you've got a very foreign-looking tumor, as opposed to a tumor that's only got a couple mutations. It's harder for your immune system to distinguish that from a normal cell. This is what I mean by the difference. And so if you look at these are several large trials, and in blue are everybody in the trial compared together. And if you see over there on the top left, the blue line is pembrolizumab and the purple line is chemotherapy. And you see that there's no real difference between these curves when you look at everyone all together. However, it's totally flipped if you look at the MSI-H patients. Now you see the green curve is way higher, and the proportion of people alive at 12 months is now 73% compared to 25%. So it's a massive difference if you have an MSI-H tumor, and that's true whether it's Keynote-61, which was a second-line trial, or Keynote-62, or pretty much any data set that you look at. The MSI-H patients do much better with immunotherapy. So stomach cancer patients really need to know, have they had MSI-H or MMR testing, and what is the result? So we'll talk about a couple new kids on the block. Actually, when I was making this lecture, I realized there was actually a New Kids on the Block cartoon, which I had never heard of. I didn't actually go back and watch any episodes, but maybe someday. So one of the new kids on the block is adding immunotherapy to HER2 positive stomach cancer. So again, up top is the overall treatment. And so now you're in the first line after diagnosis. And we know that adding the HER2 therapy on top of chemo improves the survival for HER2 patients. I just showed you that a couple slides ago. Now there was some nice work by some friends at Memorial Sloan Kettering to suggest that adding immunotherapy on top of chemotherapy and the HER2 drug Trastuzumab further improves outcomes. So there's been a big phase 3 trial called Keynote-811 where they compared people, and I'm showing the blue and the red, the people who got 5-FU and oxaliplatin and the HER2 drug Trastuzumab. When you added immunotherapy, the response rate was almost 75%. Compared to the group without immunotherapy, the response rate's around 52%. So this is an impressive early reporting of this trial. We don't yet know if those patients are living longer, which is obviously very important, but we do know that much more of them are having their tumors shrink, and that's usually associated with feeling better and pain and symptoms and fatigue and all of those things improving. So this was a recently approved FDA combination in May of 2021. Similarly, if you look at the HER2 positive patients, after you've gotten trastuzumab containing therapy, the question has always been, well, what if we keep hitting the HER2 target? Because we know that the tumor originally had a HER2 overexpression. And there's a new drug called trastuzumab deruxtecan, or TDXD if you want to sound cool. And this is for HER2 positive patients who have progressed. So the trastuzumab eventually failed the patient, and now they need something next. So now you're talking in the second line and third line. And here, this drug has shown activity, response rate in the 38 to 50% range. This drug is also approved since January of 2021. And it is another option for patients with HER2 positive disease. There's a lot of other targets that we don't have time to go through, maybe at another lecture, but again, this is a review of standard therapies, not new therapies. So these are questions for your care team in advanced disease. So what are the biomarker results for my tumor? Remember, HER2, PD-L1 with the CPS score, and mismatch repair or MSI-H are the bare minimum. We and many other academic centers do DNA sequencing and test for hundreds of different genes, but that is not yet considered completely standard. It's always good to know where you stand in that treatment line. Is this my first line? Is this my second line? Is this my third line? And so if you're ever confused, just ask. Are there clinical trials available? To me, this is a very important question. We know that the standards are standard, but we also know that they're not good enough. And so a lot of our job is to improve the standards, and we do that by clinical trials. And then always a good question is, are we ready to do this thing? Do we need any more testing before we start this treatment? Do we need a new scan? Do we need a new biopsy? Do we need a new blood test for something like circulating tumor DNA? The reason is that we're sort of starting to think about stomach cancer more like this. So the top is the standard, and it's really, you do your biomarker testing in the very beginning when you're diagnosed, then you get your first line treatment, and then chemo stopped working, and then you decide, and you get your second line and third line, but we're not using any biomarker information. We're not using any specific testing about your tumor to make the next recommendation. That is sort of the older way of doing it. The new way is starting to think about it where we do this as a iterative, like a repeat. So you get as much information as you can. You pick the first line with all that information. Eventually, the treatment fails the patient, and then you repeat all that. So you learn as much as you can about the tumor again. How did it do that? How did it figure out a way around this chemotherapy or this HER2 therapy, etc.? And then you use all that information and you pick the second line, and the hope is that we do a better job picking and it lasts longer and it works better so that people live longer, and that's what the red dotted line here is trying to show. And then you get it, you just repeat that knowledge and learning process and try to pick the next best therapy, and I would insert clinical trials into all of these stages if they're available and near to you. So I'm wrapping up. I want to direct you to places where you can learn more. So each other, you're at this symposium, that's a huge step. A lot of other people here to learn, and so ask each other, talk to people, join a group, ask your doctors, your care team, your nurse practitioners, the nurses, etc. Places like Debbie's Dream and other events like this are really good starts. Maybe you watch this webinar or share this lecture, which will be recorded. The NCCN, which is public and freely available, has a lot of this information for patients in multiple languages. Count Me In project is a way to get involved in research that's totally free, and anybody can sign up. And then finally, I'm half joking, you can call Andrea Eidelman, who's the Debbie's Dream CEO, and someone needs to have that number as their cell phone. I don't know anyone who does, but maybe I'll try to do it someday because it's a good one. So the take-home points. So staging is really critical. Doing it right is better than doing it fast. Don't forget a diagnostic laparoscopy. If it takes 10 days to get from your first diagnosis, get all the testing done, or even longer, as long as it's being done right, that's probably okay. Localized disease needs to be tested for MSI-H or mismatch repair deficiency. This might impact the treatment approach. Those patients don't appear to benefit from chemotherapy very much, if at all. Biomarkers teach us about your tumor. This is absolutely required for all stage 4 patients. The minimum is HER2, MSI, and PD-L1 with the CPS score. The standards are the standards, and that's what we talked about. That's the data. But trials are how we improve outcomes, and certainly we try to offer trials to patients at every stage of the journey. Here are some topics for another day that you can ask, and this is DNA sequencing, liquid biopsies, new targets, germline testing, and I'm sure you'll hear other talks on these topics. So I want to thank you all for your time. Here's my information if there's any questions, and I hope you all enjoyed and got something out of this lecture. Thank you very much.